I don't have any prudent investments in any of the medications I'm going to talk about today to declare to you. But I think that we have entered a new era of success in treating a lot of the arthritic conditions, and there are a number of clinical trials that are underway now, and I'm going to touch on a couple of things that I think will be fun to talk about, and I welcome a chance to discuss with many of you afterwards. So, rheumatologists, we deal with all sorts of different kinds of conditions. Many people come into the office not knowing what a rheumatologist is, and they've just been urged to come see us by their pediatrician or their ophthalmologist. And in some respects, we're the consultants of last resort. We see so many people who have seen a number of other doctors before they get in to see us. And in some respects, the thing that knits together all the rheumatologic conditions is that we don't know what causes them. So we are experts in confusion. And when we think of rheumatologic diseases, typically we're talking about what are called the diffuse connective tissue diseases. In my first category here, obviously we're talking today very much about juvenile idiopathic arthritis. But this includes things like the spondyloarthropathies, diseases that include arthritis related to psoriasis and Crohn's disease. It also includes lupus and the lupus spectrum disorders, which are inflammatory diseases of the muscles, sometimes of the liver and the thyroid. So our focus today is going to be mostly on juvenile idiopathic arthritis, and I'm going to talk to you in a moment about some of the confusing terminology that we have in the field. But there are some more sort of down-the-list diagnoses that we see in rheumatology, and interestingly, many of them are associated with inflammation in the eyes. So they include things like inflammation in the blood vessels or vasculitis, and particularly of the type Kawasaki disease, which affects very young children, and we think of it as mostly affecting the heart, but it also can cause inflammation in the eyes. Behçet's disease, which is concentrated in the Middle East and in the Far East. Granulomatous disease, which is sort of a cousin of Behçet's, sarcoidosis. Then we have a variety of we think of them as congenital disorders, but they're autoinflammatory disorders. There's a huge new literature now looking at diseases like Blau's syndrome and SINCO, which is the infantile neurocutaneous and arthralgia syndrome, SINCO or NOMID. And these two conditions, Blau's syndrome and SINCO, both represent mutations in the sensor proteins that initiate immune responses. They're part of the innate immune system. And for reasons we don't really understand, these two conditions are associated with uveitis, but not a whole group of other related diseases like familial Mediterranean fever, which is much more common than SINCO is. And then lastly, one thing we always keep in the back of our minds when we see Dr. Foster's patients is, could this be one of those rare infections? Now, we think of them as rare infections because we don't find too many patients who turn out to have toxoplasma infection as the cause for their uveitis. But as many as a third of all of the people in the world have been infected at some time with toxoplasma, which is a protozoal agent that gets carried around by our cats. So this may be more common than we realize. And of course, here in New England, Lyme disease we always have to worry about. So I spent this past year working at the University of Southern California in Los Angeles, and I saw quite a universe of uveitis patients there. I had a chance to appreciate just how good the care is here in Massachusetts for kids who have this significant threat to their vision. And I was in a division there at Children's Hospital in Los Angeles that uses the new terminology, juvenile idiopathic arthritis. This is a term that was developed in the late 90s to try and bring the Europeans and the Americans together, because for many years there had been this clash of terminologies. So you'll see if you go back into the literature that oftentimes in American studies the condition is referred to as juvenile rheumatoid arthritis, and in Europe it was referred to as juvenile chronic arthritis. So they tried to bring the two together in the late 90s in two consensus conferences, and they'd settled on the wholly unsatisfying term, juvenile idiopathic arthritis. So idiopathic related to the word idiot, like we have no idea what's causing this. And juvenile, obviously, it's youthful and often it's associated with arthritis. So what are the comparisons between these things? I think this is helpful to talk about for a moment because when you go online and you Google this stuff, you'll see references to this or that, and it can be a little bit confusing. So in the classic American College of Rheumatology terminology for juvenile rheumatoid arthritis, we typically divide it into three groups. Systemic disease, which Nida talked about a moment ago, which is really a different disease, very rarely associated with uveitis. Uveitis is really more of a concern for these other two categories. Pauci, meaning few, 4 or fewer joints. So pauciarticular, polyarticular, 5 or more. And just skipping over to the International League for the Association of Rheumatologists, ILAR, or the JIA terminology, what they've done essentially is taken all of this other group of arthritis types related to psoriasis and similar kinds of arthritis, which are asymmetric, more painful than JRA, and lumped them in with JRA to create the JIA classification. So if you want to think of it simply this way, JRA is sort of a subset of all the kids who have unexplained inflammatory arthritis. JIA includes a few extra kids who have a slightly different form of arthritis, and my sense is that we may see the terminology circle back around to the original JRA terminology. Now that we have a means of looking at gene signatures in these different diseases, there's increasingly a perception that the splitters are going to win. So we're going to be able to split these things back out again, and hopefully this will have important implications for therapy down the road. So what are we talking about here? Well, if you look at the JIA subtypes, the dark ones on the top, about half of all of the patients that we see who have arthritis, unexplained arthritis as a child, are in groups that are susceptible to the development of uveitis in the eyes, and particularly this group in the top left corner, the oligoarthritis, which incorporates that JRA group that we called pauciarticular JRA. This is a paper that came out recently that tried to revisit the question of some of the characteristics of the children who develop uveitis. And well, what you can see if you look here, this is a group of 62 kids who had arthritis. And if you look at the median age, the third line down, at the diagnosis of JIA, what you'll see is that the girls were considerably younger than the boys. The range of the 40 girls here who had uveitis and arthritis were as young as 12 months old. The youngest boy was almost 3 years old. And you can see that the median age of diagnosis was 4.5 for the boys and 3 for the girls. So for some reason in this early group of patients, girls seem to be much more involved and much more seriously involved. Interestingly, I think the most interesting numbers on this page are down in the fourth line. You can see in those children who developed arthritis and uveitis, and ask the question, which ones developed arthritis before the uveitis? If they have arthritis, this is like a big red flag for us. We better get them into Mercy to have their eyes examined. But if they don't develop arthritis ahead of time, these kids can have this insidious onset of eye inflammatory disease. They're often harder to catch. And one of the fascinating results here is you can see under the girls, 95% of all of the girls who developed uveitis had arthritis first. So the more typical disease course for these young girls was that they got one swollen knee, and then they went in to see the ophthalmologist and were found to have inflammation in their eyes. In contrast, only half of the boys had arthritis before they had uveitis. My own sense is that often the boys that I've seen, especially this last year in Los Angeles, had more severe uveitis than many of the girls, and I wonder if it's just because we didn't catch it as early as we otherwise might have. Now, this is illustrated in a paper that came from the Hospital for Sick Children in Toronto. It came out 2 years ago, and I thought this was just such a dramatic representation. You can see here is the girls on top and the boys at the bottom. And what you can see is that there's dramatically more arthritis in the light-colored bars among girls very early on. And then they also have more uveitis compared to the boys. And what you can see that's really striking is that for girls, the development of uveitis is very much age-associated. So if a girl has onset of uveitis or arthritis before age 2, and she's positive for this test that we use in rheumatology, the ANA test, there's a much higher likelihood that she's going to go on to develop uveitis. And the numbers from this paper suggest that 50% of those kids will develop inflammation in their eyes. So there's something about having the onset of the disease very early in life in a girl who turns out to be ANA positive for the likelihood of developing parallel inflammation in the eyes. And the boys just sort of simmer along here all the way through childhood. So for some reason, age doesn't seem to make a big difference for boys. Well, this has important implications for screening, and I'm going to talk a little bit about that in just a moment. So what is the typical presentation for our patients who have these different kinds of conditions? Well, the oligoarthritis subtype of JIA is, as Nita mentioned a moment ago, affects about 30% of those kids develop uveitis. I mentioned the female predominance, the relationship to ANA. There are other genes that are associated with the development of uveitis, and these are in the human leukocyte antigen complex. It's an area on chromosome 6 that's often used for paternity testing because it differs so much from one person to another. So there are some particular genetic markers that may lend a likelihood of developing uveitis, but we don't really have a uveitis gene that tells us precisely at this point who's going to get it and who's not. Now, I think one of the most interesting things is the difference in the presentation that we see. When we see one of these kids who comes in with pauciarticular JRA or the oligoarticular JIA, typically they're asymmetric. They've got one knee that's normal and one knee that's big and swollen. Oftentimes they have no symptoms. They'll be playing happily, sleeping fine, but the parents notice one day, wow, there's this huge knee in my child when I'm bathing them in the tub. In contrast, uveitis is less common in this other group of kids who have many joints involved. The polyarticular form of JIA typically is much more symmetric. It's much more likely to involve the upper extremities, including the wrists and the MCP or metacarpophalangeal joints in the hands. So in some respects, these are very different diseases. Upper extremity, not uveitis. Lower extremity, more likely uveitis. Painless swelling in the knee, more likely uveitis. Positive ANA, more likely uveitis. So we have these little clues that are sort of contributing to some broader understanding of what the pathogenesis is. Now, I mentioned that the swelling in the knee of these very young kids is usually painless, but the exception is an overlapping group of kids who turn out to develop psoriasis or have a family history of psoriasis. So psoriatic arthritis is also associated with uveitis. These tend to be like the oligo-JIA patients, lower extremity, asymmetric, but they're more painful and the arthritis is a little bit harder to treat. They also develop odd asymmetric swelling in one toe or one finger that we refer to as dactylitis. And then lastly, we have this sort of odd wastebasket group that's in the JIA classification called enthesitis-associated arthritis. Highly unpronounceable, but the enthesis is the area where a tendon connects to the bone. And so inflammation in those connections is associated with asymmetric arthritis. We tend to see it a lot in kids with Crohn's disease and with psoriasis. And they also have a predisposition to uveitis. So how do we take care of these kids? Well, typically, if they're of this oligoarthritis subtype, again, oligo meaning a few, these are younger kids, asymmetric arthritis, lower extremities, sometimes painful. They generally have a good prognosis. We start them off with nonsteroidal agents like naproxen, and if they have resistant swelling in one of their knees, we'll put intra-articular steroids in. So I know many of you have been through this experience now, either in the rheumatologist's office or in the interventional radiology suite. Only occasionally do we end up having to put kids like that on methotrexate. When you start getting into a more aggressive disease like psoriatic arthritis, we tend to move more to methotrexate and to anti-TNF drugs, other biologic agents. And then the enthesitis-associated arthritis is increasingly treated in the same way with methotrexate and the anti-TNF agents, although many of you may have had your kids on sulfasalazine, which is the European preference, but it's so much harder to take because you have to take it 2 or 3 times a day. They're big pills, a lot of complaining. Okay, so I alluded before to Ron Laxer's group in Toronto developed this whole new body of information that we can use to sort of study who needs to be screened and how often. And basically, if you focus on these 3 characteristics that I described a moment ago, the ANA test that we use, the age of the onset of the arthritis, the type of the arthritis, then that can give you sort of a general guideline of who needs to be screened how often. So if you'll think back to my graph with the girls swooping down there, the kids who have onset before age 2, who are ANA positive, are kids who need to be screened more often, probably every 3 months or so. And if they have had disease for less than 4 years, that's a third characteristic which would take into consideration for this frequency. If they're a boy who had onset after age 6 and they have a negative ANA, you're down in the bottom group where probably about every year is a reasonable frequency. So taking into account those factors and the activity of their eyes in the past, if they've had uveitis in the past, then you're going to screen more often. Let me just spend my last few minutes here talking about some of the medications that we use. Methotrexate is always very scary to families because when you go online, you find gobs of stuff about the use of methotrexate in treating cancer, breast cancer, and lymphoma. At much higher doses, the side effects are much greater. My experience has been so good over the years. Methotrexate is really a very safe medicine, and some of the early fears about methotrexate actually causing cancer have been shown now very conclusively, I think, to be not correct for the low doses that we use in the rheumatic diseases. There was a paper that came out about 10 years ago in adults with rheumatoid arthritis that showed that people on methotrexate live longer than people who aren't on it. So it may be that we'll all be taking it eventually. But it's just to cite a couple of things, you may ask yourself, why does my child have to get their blood drawn every 2 months when I come in to see the rheumatologist? The reasons have been classically because of concern about liver fibrosis and about anemia and loss of our white blood cells. So we monitor a CBC, ALT, and AST, which are liver tests. But now I think there's pretty good evidence in kids, just going back to a paper in 2005, that liver fibrosis almost never occurs in children. It's more a problem of people of our generation who have had environmental insults to their liver that methotrexate doesn't deal well with. So we don't have to worry about fertility problems in kids who have been on methotrexate. We do have to worry a lot about kids who might get pregnant in their teen years who are taking methotrexate because it causes pregnancy loss and it can cause birth defects in kids who don't lose the pregnancy. Let me talk for just a second about the TNF agents. There's a whole club now of different options for anti-TNF. Nita was talking a moment ago about how etanercept or Enbrel doesn't seem to be effective for uveitis, but infliximab, which is given as a bi-monthly infusion, or Humira adalimumab, which is every 2 weeks subcutaneous, certolizumab and golimumab are drugs which seem to be pretty effective. We don't have great data yet for the bottom 2, but Humira seems to be now, I think, a very reliable option for us. In terms of safety with these things, everybody's been worried about the cancer risk. Now we know in adults from huge population studies in Scandinavia looking at all the people with rheumatoid arthritis, there is no increased risk with the anti-TNF drugs for the development of lymphoma or other cancers. Unfortunately, these diseases aren't well enough studied in children for us to say definitively that cancer doesn't occur in kids who are treated with these medicines. And at our last meeting, one of my colleagues from North Carolina was very insistent that we need to worry about this because at Duke they had a series of cases of kids with Crohn's disease who developed cancer on infliximab or Remicade. There is new data now, I think, which gives us some reassurance that with Humira, which increasingly we're using in our uveitis patients, when you look at a very large number of patients, including those who have JIA, if you scan down this list, basically you can see that in this very large cohort of 23,000 patients, there was a small incidence of serious infections, but there was no lymphoma and there was no melanoma. So the malignancies other than those also were not detected. Let me just say a real quick word about CellCept mycophenolate, which many of the kids are increasingly on now. Like methotrexate, one of the problems with CellCept is that you won't respond to a vaccination once you're on the drug. So it's not a bad idea to go ahead and get the flu shot, but it's not going to give you the kind of vigorous protection against influenza that we would want. By and large, kids do very well in terms of side effects. They don't develop the anemia and neutropenia that can be seen at higher doses, 3 grams a day, that is used in kidney transplant patients, for instance. But this is why we keep checking those blood counts in kids who are on CellCept. CellCept is like another drug that we use, rituximab, in that it can expose you to a risk for rare chronic viral infections like the BK virus, and there's another infection called PML, or multifocal leukoencephalopathy. These are things that are scary when you read about them online, but they're so haltingly rare that I think by and large they're not something we need to worry about. There are new tests that are coming out, and it may be that soon part of the routine evaluation at the beginning of therapy will be to test to make sure you don't have the BK virus or the PML virus. Rituximab is a lymphoma therapy that was developed, a monoclonal antibody against a B cell protein. It kills all the B cells in the body. This is something which is under investigation now for uveitis. We use it a lot, increasingly, for JRA, because in contrast to all the other therapies we use, rituximab is one that you can give once at the beginning of a course of therapy, and many kids will go into remission. You never have to treat them again. So it's not one of these ongoing chronic therapies like everything else we use. And of course, this is an ideal that we aspire to in the inflammatory diseases. How could we treat somebody definitively, re-educate their immune system, and then not have to put them on therapy for life with all of the incumbent problems with immunosuppression? So, in summary, JIA-associated uveitis is a problem for vision, particularly in these young girls, ages 1 and 2, who have a positive ANA. There's an uncertain relationship, as we just heard about the relationship. Why do some kids develop more arthritis and some kids more uveitis? That's something we really don't understand. I still like to encourage people to use methotrexate and not be scared by it, because at least for the arthritis, it's still the most effective drug that we have. In all the head-to-head trials with the fancy TNF drugs, methotrexate is still as effective. And fortunately, we can combine methotrexate with many of these other therapies and get even more effectiveness. Lastly, we have these new therapies that are under consideration. I was seeing just this week in the news, there's a drug that's called gevokizumab, which is in European trials for uveitis associated with Behçet's disease. And this is a drug that's given as a subcutaneous injection once a month, and it was actually developed as a diabetes drug for type 2 diabetic patients. It helps to protect the cells that make insulin in their pancreas. So this is an anti-IL-1 beta drug. It's a whole new area for therapy, potentially, and it has some of the same side effects that we see with the TNF drugs in terms of susceptibility to infection and so on. But I think this is actually a very exciting time for patients who have these problems. I think that looking over the next 10 years, we're likely to be in a much stronger position to be able to treat kids definitively, to protect their vision, to keep them growing well, and to keep them functional, fully functional through all the activities of their childhood. So let me end by just thanking Dr. Foster and Dr. Hinkle, who have been really great partners and collaborators over the years, and also Allison and all the staff at Mercy, who've done such a great job organizing this conference.